retinal dystrophies, vision, loss of vision. Initially at birth vision was there, but gradually the child lost vision.
इसमें भी दो चीज़ है, आपने बोला इनहेरिटेड, राइट? दैट मीन्स फैमिली हिस्ट्री हो, तो उसमें भी आपका जो लेंस होगा देखने का वो अलग.
If you count the number of base pairs, it is approximate 3.3 billion base pairs.
Okay. आपको कौन से तरह का कैंसर हो सकता है, राइट? क्या आपने कोई ऐसा केस देखा है जहाँ पे किसी को स्टेज 4 कैंसर हो?
As of today, as we are talking, the treatment approach to all the cancers have changed.
Okay.
So the number of genes that are hosted in these chromosomes decreased from 1 to 22. Now, out of this 3.
Is nutrition greater than genetics?
Cancer is a molecular genetic abnormality. It may or may not be inherited.
Okay. Nutrition अच्छा है. तो what are the chances you can do away with? I was reading about this thing called gene editing. It's a sci-fi concept. I don't know. कि आप डिजाइनर बच्चा पैदा कर सकते हो विद जीन एडिटिंग. आपको जिस तरह से आँख चाहिए, जैसे आपको फीचर्स चाहिए, आँखों का कलर चाहिए. Is that a possibility in the future? What do you think? नमस्ते एंड वेलकम टू बिटवीन लाइंस. बिटवीन लाइंस एक कॉन्वर्सेशन लेड प्लेटफॉर्म है जहां हम डिफरेंट डोमेन्स के एक्सपर्ट के साथ बैठकर सिर्फ इन्फॉर्मेशन शेयर नहीं करते, बल्कि उसका रियल वर्ल्ड मीनिंग समझने की कोशिश करते हैं. गोल सिंपल है, नॉइज़ के बीच क्लैरिटी लाना, हेडलाइंस के नीचे छुपा हुआ लॉजिक समझना, हाइप से दूर जाना, जार्गन से परे. मैं हूँ आशीष शर्मा और यह हम सवाल पूछते हैं जो अक्सर पूछा नहीं जाता और उन जवाब तक पहुंचने की कोशिश करते हैं जो आपको डिसीजन मेकिंग में हेल्प करेगा. आज का एपिसोड जेनेटिक्स और हेल्थ डिसीजन पर फोकस्ड है. हमारे साथ है डॉक्टर अनूप राहुल, जो एक लीडिंग मेडिकल जेनेटिसिस्ट है और सहस जेनेटिक्स सेंटर के फाउंडर भी है. इसके साथ ही उनकी एक्सपर्टीज़ है कैंसर जेनेटिक्स, प्रिसिशन मेडिसिन और रिप्रोडक्टिव जेनोमिक्स में. फ्रेंड्स, इस कॉन्वर्जेशन में हम जेनेटिक्स को सिर्फ टेस्ट, रिपोर्ट्स या टेक्निकल टर्मिनोलॉजी के लेंस से नहीं देखेंगे, बल्कि उस सटल लेकिन पावरफुल रोल पर भी बात करेंगे जो जेनेटिक्स एवरीडे हेल्थ डिसीजन में क्वाइटली प्ले करता है, अक्सर बिना हमें रियलाइज़ किए. जेनेटिक्स को काफ़ी लोग डेस्टिनी भी कहते हैं, लेकिन रियलिटी थोड़ी डिफरेंट है. जीन्स इंफॉर्मेशन देते हैं, कॉन्टेक्स्ट भी देते हैं, लेकिन आउटकम हमेशा फिक्स्ड नहीं होता. ज़्यादा इम्पॉर्टेंट है सही सवाल पूछना और रिजल्ट्स को सही तरीके से इंटरप्रेट करना. इस डिस्कशन में हम ये एक्सप्लोर करेंगे कि जेनेटिक्स कहाँ जेन्युइनली यूज़फुल है, कहाँ लोग अनरियलिस्टिक एक्सपेक्टेशन बना लेते हैं और कैसे साइंस को प्रैक्टिकल रियल लाइफ डिसीजन मेकिंग के साथ अलाइन किया जा सकता है. इंडियन कॉन्टेक्स्ट में ये कॉन्वर्सेशन और भी रेलेवेंट हो जाती है क्योंकि यह बायोलॉजी के साथ फैमिली हिस्ट्री, सोशल स्ट्रक्चर्स और कल्चरल डिसीजंस डीपली इंटरट्वाइंड होते हैं. इसी बैलेंस्ड और रियलिस्टिक पर्सपेक्टिव के साथ आज हम डॉक्टर अनुप राहुल के साथ जेनेटिक्स को क्लियरली, रिस्पॉन्सिबली और ग्राउंडेड तरीके से समझने की कोशिश करेंगे. फ्रेंड्स, ये वीडियो आखिर तक देखना और प्लीज़ मेरे चैनल बिटवीन लाइंस को सब्सक्राइब ज़रूर करना. थैंक यू डॉक्टर अनूप फॉर दिस टाइम विथ मी ऑन माय पॉडकास्ट. तो सबसे पहले मेरे को ये जानना है सर कि मेडिकल जेनेटिसिस्ट, राइट्स, इट्स अ गुड वर्ड टू हियर. यूजुअली हम ज़्यादा सुनते नहीं है इन द फील्ड ऑफ MBBS. तो अगर आप चार्ट आउट कर सकते हो आपकी जर्नी, हाउ यू स्टार्टेड और आप कैसे यू थॉट ऑफ चूजिंग दिस फील्ड ऑफ मेडिकल जेनेटिक्स, इफ यू कैन एक्सप्लेन इट वुड बी वेरी हेल्पफुल.
So definitely medical genetics as a branch is still not much known in the medical fraternity.
Okay.
It's a newer branch, newer specialty.
Okay.
But the DM course has been there for around like 15-20 years maybe. It started in 90s in SGPJ Lucknow.
Okay.
So my journey towards genetics, I never thought I'd become a geneticist. You can say luck by chance. So I did my MBBS, MD medicine from MGMS Sevagram.
Okay.
And that's a central government institute, a rural medical college.
Okay.
And for any government college, you know what's the workload like. For MD medicine, it's too hectic. at a stretch. You do duties for 2 days, 3 days at a
Okay.
stretch, and it was very hectic. So MD खत्म करने के बाद it was like I'm not going to study any further. I'm saturated. I'm done. बस अभी will work
Right.
and that's it. So I never, I didn't even give attempt for any super specialty after that.
Okay.
So 2-3 years. So I came to Pune. I joined Sinhagad Medical College and I was working.
Okay.
Then there were few incidences that happened, personal, in family, professionally.
Okay.
Then they pushed me on two fronts. One is like MD medicine करके रुकना नहीं है, कुछ आगे करना है. Then only you'll get a recognition because every year thousands of MD medicine graduate
Right.
from various medical colleges in India. So you're just one of them. And growth, progress, recognition, उस level पे it becomes difficult. Coming to a place like Pune, getting into the medical field, medical practice for MD medicine, there's lots of competition.
Was it? Oh,
That
sorry
time,
to.
I'm talking about 2011.
Oh, okay.
ठीक है 2011 2012. So and अभी just MD खत्म किया है, घर के expectations होते हैं कि यार MD खत्म कर लिया, now he's working, he's become a doctor.
Yes.
And at the other end you're just struggling. There's no backup. So that was one front. And second, there was some personal crisis.
Okay.
We had some issues where at that time we are not able to find answers. We did some tests for us, genetic tests.
Okay.
But being a MD medicine, I was not knowing what are these tests, what do they mean.
Okay.
I was relying on someone who's a non-medico to understand things. That was a bit unnerving for me कि यार ऐसे कैसे medicine पढ़ लिया but still this part I don't know. That was one trigger. Second trigger that happened is then I started searching for a job switch.
Okay.
And then luckily I got to work in a lab. There was just a random advertisement that came. I thought let's apply, and I joined a genetic lab.
Okay.
They wanted a medical person to liaison between them and the clinicians.
Okay.
I thought let's try it out, something new. And that is how the journey started. Now, okay, I started learning. I started interacting with the lab people. Lab people, all of them were MSc, PhD, BTech, MTech and all those lab guys. Started learning with them and started reading. Then I realized that in medical curriculum, genetics is not covered to the depth, and as a specialty it has not involved.
Okay.
So then I started understanding what are the limitations, and my journey started in cancer genetics that time. So okay, because right now if you see, cancer genetics is a field where molecular oncology, like treatments are based on molecular genetic tests.
Molecular genetic
Testing.
tests. Okay. Okay.
So you test the tissue, you test the blood, you find out what are the various mutations, what is the pattern, what are the pathways involved, how is that going to affect the treatment, how the prognosis is going to be, can I use this drug, or this drug cannot be used because of the patient is prone to side effects, or he may not get optimal therapeutic benefit, or some drug I know this is the pathway, this is the mutation, this drug is going to work. So that's how the treatment is evolving. And this was like 2013.
Okay.
That time I joined a lab. So then I started fathoming things, and I realized that time all over India there was just one official DM medical genetics course that was in SGPJ Lucknow. There were 2 seats, that's it, all over India.
Right.
And I thought, let me give it a try. What are the other backup plans? Other backup plans was like doing a PhD in genetics under MHS. They also had an entrance exam that time. It's there now also.
Right.
And then in CMC Vellore there was a postdoctoral fellowship for 2 years. That, but only 1 seat.
1 seat.
Yeah. So, and then there was DNB genetics that had just started. I think it had been 1 or 2 batches, I think, before that. And there were only 6 seats. So that's how I started. Then I gave my first attempt. तो पहले 1-2 साल तो समझने में, पढ़ने में, and whether I should do it. Then I realized कि I don't want to do conventional branches. I don't want to do MD medicine. I don't want to do, DM, cardio, neuro and all that stuff.
Exactly. तो मेरा अभी जैसा आपने कहा, right, you don't want to do the conventional thing. So I was coming at the question, क्या while studying genetics, right, that time, did you realize or did you have a feeling that this would be the future of hospital management or treatment management?
Yes. So ये जो sort of insight I had when I was working in the genetic lab even before going for DM. Because then I realized, okay, testing हो रहा है, oncology में कर रहे हैं, and it is coming up a large way. Because before that, conventionally how oncology is practiced, if you have a tumor, you take the tumor, you do histopathological examination, you do the grading staging, and based on that, treatment is set. Like you either give chemo, followed by a surgery or a radiation, or you whatever the guidelines is, that way you do it.
Right.
But as of today, as we are talking, the treatment approach to all the cancers have changed.
Okay.
Firstly, the classification. Initially, it was like you take the tissue, you prepare slides, you see under microscope, you put stains and all, and you observe and then you classify. Okay, what is the pattern on histopathological examination on microscopy? That's how it was. But now, everything is based on molecular. You do a molecular genetic testing for those tissue.
Okay.
And now this is standard classification for most of the cancers now. So based on that, how it is going to fare, how the prognosis is going to be, what medications are going to work, what therapy is going to work. So now that has changed. So that insight sort of I got when I was doing the job in genetic lab. And when I went for DM, so there all seniors or colleagues, everyone was either Ops, Gynae or Peds.
Okay.
I was the only MD medicine then. Right now also there are hardly 2-3 MD medicine who have done DM. Right. So everyone out there, and right now conventionally everyone focuses, when you talk of genetics, everyone thinks of congenital anomalies, pregnancy, reproductive genomics, inherited disorders, inborn error of metabolism. So everything evolves around pregnancy, fetus, congenital anomalies, and children with congenital and genetic abnormalities. But there is much more beyond that.
Get it.
So you talk of nephrology, renal transplant, renal disorders, right? You talk of neurology, neurodegenerative conditions, Alzheimer's, Parkinson's, spinocerebellar ataxias, degenerative disorders of the cerebral cortex, right? In children, neurodevelopmental disorders.
Okay.
So these are all genetic. Then you talk of ophthalmology. So some children get cataract at a young age, or retinal dystrophies, vision, loss of vision. Initially at birth vision was there, but gradually the child lost vision because of some congenital anomalies in the retina. That's the cell layer that senses the light and then sends the signals to the optic nerve and to the brain. So all these conditions are genetic. Then there's inheritance pattern. At some places you can, therapies have come up, particularly in the eye conditions, where if you do a test, you find a particular mutation in particular gene, you can give therapies, local therapies in the eye, and actually cure it. So this is where it is heading. So, and it's heading at a very rapid pace. And I think the major shift that happened was the COVID. So historically, if you see, say smallpox, that was a viral disorder for which the first ever vaccine was made, right?
Early 1900s, right?
It's 60s, 70s, I think. The first vaccine which was ever made, and the research that went on to make that vaccine span decades. But if you look at COVID, in record few months time,
we came up with the vaccines.
You decoded the virus, you understood the genome, you understood the target areas which are required to induce immunity in humans. You developed a vaccine, and rest is history.
No, I think you're right. I think this is the case with every kind of innovation, whether it's in the field of medicine, healthcare, technology. जितना हम आप पहले देखोगे, धीरे-धीरे compounding होता है, and then the speed increases, right? You rightly said that. And you also mentioned about pregnancy. I'll come to that. But before we move, अगर आप simple language में explain कर सकते हो, what's the difference between DNA and genes? Because ज़्यादा करके confusion लोगों को वही होता है कि DNA और genes क्या same है.
Yeah, so very basic questions, and I think thanks for bringing this up. We should have discussed it much before.
No.
That's yeah. So see, let me simplify things for you. I'll give you a parallel example. Maybe that will help you understand better. So we are sitting here. we have a library of books, say 46 books.
Yeah.
Or 23 pairs, 23 books, and you have 2 copies of each book.
Okay.
Right.
Yeah.
So that's a library we have.
Yeah.
So if we look into a cell, human cell, let us look into the human cell. There is cell membrane, there's cytoplasm.
Okay.
In cytoplasm, there are various organelles.
Yeah.
And then you have nucleus.
Nucleus, yes.
In nucleus, you have the chromosomes.
Yeah.
Right. So there are 46 chromosomes or 23 pairs.
X and Y, right?
So, yes, coming to that. So,
sorry, I'm jumping.
no, that's absolutely fine.
Yeah.
So 22 pairs are autosomes, and last pair is the sex chromosome pair.
Okay.
Either it is XX or XY.
Okay.
That determines the gender.
Okay.
So XY is male.
Male.
XX is female.
Female. Okay.
So that determines the gender, and rest are autosomes in pairs.
Get it.
So that is, if you, to simplify, we have 2 copies of DNA in each nucleus.
Okay.
1 copy of DNA is divided into these 23 chromosomes. So 123 set of chromosomes and another 23 set of chromosomes. 2 DNA copies, 1 DNA copy coming from each parent.
Okay.
So that's how it is, right?
Get it.
So when I'm talking of this set of chromosomes, I'm talking about library of books. That is the chromosomes that we're looking at. And 1 DNA, it is divided into these chromosomes. So you have 2 copies. So it's a script.
Right.
So what is DNA? It's a double helical structure, like a ladder, which is twisted. And then there are nucleotide base pairs, A, T, G, C, which are positioned by hydrogen bonds and so on.
Right.
So this entire strand, it's like, if you count the number of base pairs, it is approximate 3.3 billion base pairs.
Okay.
So if you compare it with our data, what we routinely use in mobile, it's like 3.3 GB data.
Okay.
But this entire DNA, there are certain sections of this DNA, what we call as genes.
Okay.
They are hosted on this entire DNA, which code for proteins.
Okay.
And this is how the message flows from DNA. It's the messenger RNA, then the proteins.
Okay.
Right. So now if I'm looking at the library of books, so we have 23 huge textbooks, right?
Yes.
Each differing in, so textbook number 1 is the largest, 2 is a bit thinner, the thinnest is like 21, 22.
Okay.
That way. So the number of genes that are hosted in these chromosomes decrease from 1 to 22. Now, out of this 3.3 GB data, the functional part, or the genes that code for this proteins is only about 1.5%.
Okay.
So that roughly makes between, say, 40 to 45 MB.
Yeah.
So 3.3 GB में से almost like 40 MB is the coding part. So now if I'm talking of these books, so कितना भी मोटा book है, उसमें only entire library में whatever the number of pages there are, say 3.3 billion letters typed on, say
the complete book,
all this set of books, only 1.5% is meaningful to me.
Okay.
Right.
Get it.
Now, this 1.5% of the meaningful text that is there, it comprises of between 20 to 21,000 genes.
Okay. And are all these genes, ये पूरे genes active होते?
So, again, there is a variation.
Okay.
So, these 21,000 genes, उनका जो functioning है, that differs with time, with their special orientation in the body, and in different phases of growth and life.
Okay, समझ गया. तो मतलब जो genes एक 20 years के body में active हो गए.
Simple example, you have one cell in the brain, that's a neuron.
Right.
You have one cell in the blood, that's a white blood cell.
Okay.
If you look at the nucleus, chromosomes here, the genome here and genome here is the same.
True.
But if you look at the cellular appearance, that is because of the various proteins that are being produced and the functioning that is happening.
Right.
Appearance-wise, functioning-wise, both are different. But the same set of genes which are there, in different patterns. So one gene is upregulated, functioning more, other is not working.
Okay.
So this variation in the functioning creates
Differs.
these differences.
Get it. No, I think very well explained. Thank you. क्या ये सच है कि डेली लाइफ में जो आपके जीन्स होते हैं दे प्ले अ पिवटल रोल इन हाउ यू एक्ट और हाउ यू थिंक, इज दैट राइट? क्या जीन्स आपके डेली लाइफ को अफेक्ट करते हैं?
So yes, genes govern, like me sitting here talking.
Right.
Everything is happening at a molecular level.
Exactly.
So yeah. So but having said that,
Right.
Certain aspects of the bodily function are more governed or more affected by functioning of those genes.
Okay.
Other aspects have multifactorial influence.
Okay.
Like suppose if I'm talking about my digestion capacity, risk for allergy, if I'm taking certain drug, how much my body will
take it,
accept it, metabolize it, and the therapeutic effect, the benefit will be there, or there's a risk for side effects.
Right.
Propensity to certain diseases. Right. All this is genetically imbibed. That propensity or that vulnerability is genetically decided.
Get it.
Having said that, there are then other aspects where genes do have an influence.
Okay.
But that influence for a particular variant in that gene may be minuscule.
Okay.
Combined by many other variations in other genes.
Right.
And additional factors like say environment, lifestyle, habits.
Get it.
They again have a cumulative effect. So that's multifactorial.
Stress is also
stress
key,
is very important. Yeah.
Get it. Thank you. So as a as a person who is in 30s, right, or somebody in 20s or 40s, why it is important for us, for everybody individual, to know about their genes health or take it seriously? Is that critical to avoid certain things in future?
Yeah. So I'm happy you brought this up, because see, now the trend is that genetic test is a test, medical test. Right. Normally when do you do a medical test?
Normally जब अगर हमको लग रहा है कि maybe there might be an issue in the body, or there is already an issue in the body.
Illness,
yes.
Who advises you to do the test? Or who gets it done?
Doctors. Right.
I wanted to bring up this point. This is one aspect. You have some illness,
right,
or you want to know something, then the doctor advises the test. That is one. Second aspect is routinely you have this health checkups. Your office gets it done, or you yourself get it done, some baseline test just to understand what is the bodily functioning fitness right now. Right. Or routine test that happens, like someone is diabetic, hypertensive, on medicines, and you want to check on the cholesterol profile, the sugars and other things. So this is how it is.
Right.
When you're talking about genetic test, whatever is done for diagnostic purpose,
right,
from disease point of view, or if I'm looking or investigating an inherited condition or pregnancy related congenital anomalies, these are prescribed or ordered by a doctor.
True.
Right. This is one aspect. So here there is a reason why we are doing it. So I'm forgetting that this thing theorem. The post-test probability of getting something always depends upon your pre-test suspicion, clinical diagnosis, and the condition that you're thinking of. So that's how it correlates. Otherwise, if you're doing a vague test without any specific motive, chances are that you might get a neutral negative report. If you're suspecting something, you look for a focused test. Nowadays, lot many people and labs are doing such genetic test, like directly to client, directly to customer. Then there becomes a problem, because these are not diagnostic tests then. So these are like preemptive tests or predictive tests. But again, that comes with a caveat. If I'm doing it for diagnostic purpose, I know based on the report whether that risk is there or not. I'm going to use that information for prediction, for therapy, for treatment, or in future generation, what risk is going to be there, 25%, 50%, depending upon the pattern of inheritance. Can I prevent that? What can I do to modify that risk? So when I'm using it for a diagnostic purpose, the motive is very clear. Right. But when it comes to doing it from lifestyle point of view or direct to customer for preemptive, and so preemptive, these tests differ from the diagnostic tests that the labs do, because the diagnostic tests are comprehensive. So suppose if I'm looking for a patient who has been diagnosed with, say, a breast cancer, a 25-year-old female diagnosed with a triple negative breast cancer, family history is there. I know I'm going to read only those specific chapters in particular books where that gene is coding for breast cancer and to look for inherited patterns. I'm not going to
very precise.
Very precise. All those genes which are known to cause breast cancers. Right, inherited patterns. If it is there, I know it is there. If it is not there, I know it's not there. It's not inherited.
इसमें भी दो चीज़ है. आपने बोला inherited, right? That means family history होगी. और इसमें एक और केस हो सकता है कि family history नहीं है.
Correct.
तो उसमें भी आपका जो lens होगा देखने का वो अलग होगा.
Yes. So if you talk of cancers, so cancer at the molecular level, it's a molecular genetic abnormality. Cancer is a genetic disorder.
Right.
Beyond doubt.
True.
It may or may not be inherited.
Okay.
So these are two different things. So cancer is a molecular genetic abnormality. It may or may not be inherited.
Okay.
So when I'm saying inheritance, that means that genetic abnormality is being passed on from one generation to next.
Okay.
So is the risk for that particular variation. So it could be some metabolic disorder, neurodevelopmental, neurodegenerative, kidney related, and so on. Cancer is one of them. And sometimes that abnormality arises in the individual in one particular organ or tissue and is limited only to that particular individual. Both cases it is molecular genetic, but in second case it is not being inherited.
Okay.
It is just limited to that individual. So that's the difference.
Okay, get it. So I'm glad we are discussing this because मैं बहुत सुनता हूँ कि फैमिली में किसको अगर कैंसर है, समझो आपके ग्रैंडफादर को हुआ था या किसी के डैड को या मॉम को हुआ था, देयर आर चांसेस कि ऑफस्प्रिंग्स को भी हो. तो ऐसे केस में अगर अब तक डिटेक्ट नहीं हुआ है एंड देयर माइट बी अ चांस फ्रॉम डॉक्टर्स लेंस की हो सकता है, तो एनी प्रिवेंटिव टेस्ट यू वुड सजेस्ट?
Yes. So
test and also maybe something from a lifestyle perspective ki avoid.
So if you're talking of, so I'd like to quote one case which I came across 2-3 years back when I was practicing in Fortis, Mumbai.
Okay.
So there was this couple, NRI, had come back from Netherlands. Okay. Planning for pregnancy. But this individual, he was very, very apprehensive and anxious because his mother had been diagnosed with breast cancer, and he was concerned with that risk for his children. So this was like before planning pregnancy. And his concern was there because he said that in Netherlands, getting a test, getting a consultation, everything is governed by the government, and there's a lot of time, and it's not that easy what it happens here.
Okay.
So that was his concern. So he wanted to be sure. Now, his mother was a doctor. She was a pathologist who was practicing in Mumbai.
Okay.
She had expired, I think, 4-5 years back. And there was family history of 1 or 2 malignancies. I don't remember that much specific, but definitely family history was there. Now the challenge was, okay, now family history is there. Mother is no more. He's having this history, and what to do next? So I said, family tree I draw here, what I remember. And so whenever we are suspecting anything, we go through the family tree. That is one. It gives us the confidence to suspect something.
Right.
Sometimes the cancers may not be the same organ. They may be related organs. Prostate, breast, uterus, ovaries, So in different individuals, yeah. So same gene can give rise to different cancers at different ages.
Okay.
So that's the spectrum. So I just asked him, can we get her clinical details, files and all, anything if that is there. So he came back with the files and all, and mother's diagnosis was myotonic dystrophy. So this is a neurodegenerative condition with increased propensity to cancer risk.
Okay.
So what next? So I said, since she was diagnosed, can we get the blocks? So tissue blocks are preserved by the labs for a certain amount of time.
Tissue blocks?
Yeah, so tumor tissue blocks. So because we cannot test the mother,
right?
She's no more. We don't have her samples.
Right.
So can we get the blocks? Luckily, we got the blocks. We got the testing done on the blocks because clinical diagnosis was there. We did the molecular analysis, got the diagnosis. Now I said, okay, the possibility for you inheriting it is 50%.
Wow.
पहले आपका टेस्टिंग करते हैं and let's see.
So ये जो आप ब्लॉक्स की आप बात कर रहे हो, तो ये टिश्यू ब्लॉक्स उनकी मॉम की थे, right?
Yes.
And it was preserved.
It was preserved. So
wonderful.
The labs,
so they really helped.
It's a policy of the labs to preserve all this samples for a specific period of time. I think it's like 3 or 5 years.
Okay.
So luckily we got it. We got the testing done. We found the abnormality. Then we tested this guy. He was negative. Okay. So now it's total green. Go ahead. You need not worry. Nothing. Okay. But having said that, now this is for a specific disorder in the family for which risk was significant. 50% risk was there. Tested negative. Now general population risk for all those disorders which are there, that applies to him. Okay. So you do those screenings and all and go ahead. So that's how it is.
I think that's really cool. I think that tissue block really helped you.
Yeah. Detect. So otherwise there was no ways of testing, because in such situations people do test. There are doctors who advise test, but then the limitation comes if you get a negative report in this individual. Right. Is it actually true negative? You won't be able to tell that with a certainty. Okay. Because there is no single genetic test or platform which covers all the genetic abnormalities. Okay. Different genetic abnormalities give rise to different disorders, and when we have to do a test, it's a mix and match for all these tests and platforms. So for example, routinely when I have to do a blood sugar, either I'll do it with a finger prick test on a glucometer, or I'll send it to a lab. Right. So suppose I'm sending to a lab. If I'm doing functions for the kidney, creat, urea, same time I'm doing a hemogram, hemoglobin and indices. So there are different instruments and platforms to do this test. There is no single instrument. So similarly in genetics, there is no single instrument or platform to check for various abnormalities. So that is a common misunderstanding amongst the doctors and amongst the general population. Like genetic test is just one. People come with a karyotype, they say ये karyotype normal है, सब हो गया, nothing to worry. So that means like I've just looked at the library and I'm saying, oh, everything is okay. But वो library में कुछ किताबों में pages missing है. एक किताब में से pages दूसरे किताब में आ गए, किसी किताब का binding loose है. There are typographical errors, there are grammatical errors, कुछ pages बीच में blank है. Those just by looking at the library I cannot tell. So these are the abnormalities. So
clinically हर चीज हमको टेस्ट करनी पड़ेगी.
So that's what when you see a patient from, so as a medical doctor I'm looking at the medical disorder part of it, and as a clinical geneticist I'm also correlating with the molecular part of it. Okay. So as I said, like a single gene abnormality can give rise to various, so say cancers. I'm talking about say BRCA1, BRCA2. Most common and most well studied genes where you have enough data and
what's
evidence.
BRCA1 and BRCA2?
So BRCA1 and 2, these are two genes commonly associated with hereditary breast and ovarian cancer syndrome. Okay. Having said that, these two genes give rise to other cancers also. Esophageal cancer, stomach cancer, gastric cancer that is, colorectal cancers, prostate cancer, pancreatic cancer, ovarian cancer, endometrial cancer, even bone cancers. There have been associations with leukemias as well.
Blood cancer.
Blood cancers as well. Okay. At a younger age. Okay. So you see, like a single gene can give rise to so many cancers. So when I'm seeing the patient, and again in this gene, depending upon what type of molecular abnormality is there, or वो जीन में कौन से लोसाई पे abnormality है, that also gives a predisposition what type of clinical manifestation will be there.
Get it. Understood. So I think पूरे आपको deep layer पे जाके you'll have to check each and everything. You also mentioned, कि different age पे there is a spectrum of
Yes.
यू नो फ्रॉम इनहेरिटेंस आपको कौन से तरह का कैंसर हो सकता है, राइट? सो आप उसको अगर कुछ एक्सपैंड कर सकते हो.
हाँ, so if inherited cancer risk is there, so can we prevent it? Prevention, yes. It's similar for all the cancers. You cut down the risk, you cut down other factors which will have a cumulative effect. So if you know there is a risk for cancers, you are smoking, you need to stop. Dietary habits, you need to rectify. Weight, obesity is the biggest trigger.
Okay.
Insulin resistance is the biggest trigger.
Right.
That you need to curtail. Exercise. That's
Exercise.
yeah. And then your sleep, wake cycle, and diet times.
Right.
Stress that you need to manage. So all this helps in negating the risk. That is one. Second, if at all I know which gene is involved, I know what organs cancer is there, risk is there, and evidence is there. Okay, like when the risk increases or at what age the risk starts, I put those patients on surveillance then. Like
Right.
suppose BRCA1, BRCA2. I know from what age I should advise them to do a screening. So screening could be, it's not just like say self breast examination, but mix and match.
Mix and match.
Depending upon what is the pattern in that family. So alternate MRI breast with a mammography maybe. If there is risk or there is history of pancreatic cancers, I also put them on surveillance for pancreatic cancers. We explain them the red flags or the clinical features you should be looking for. Don't ignore this.
Right.
If there's anything, reach out, because the point is you diagnose the cancer early, the easier it is to treat, better is the outcome.
Get it.
And this is just the first step. Next step, okay, individual has this mutation, the pathogenic variant, what we call.
Right.
Now every pregnancy, if the couple is planning pregnancy, 50% is risk is there for the next generation.
Okay.
Can we avoid it? Yes, we can. So there are two ways. You plan for normal pregnancy, but now there are guidelines which says that late onset, adult onset, genetic conditions, testing and screening for them, there's a limitation. But then there is a pre-implantation genetic diagnosis where you go in for IVF for conditions where, you know, quality of life condition in neonatal period, or for the baby, various complications are going to be there which are going to be life-threatening, or overall the quality of life is going to be very poor. Sorry. So like say neuro developmental conditions.
Okay.
So in those situations, you go in for IVF. Once the embryos are formed in the lab, day 5 you do a biopsy of those embryos and test for that particular genetic abnormality.
If it's there or not.
If it is there or not, you take the healthy embryos and continue with the pregnancy.
Okay.
But there is a very important prerequisite that genetic abnormality should be known in the parents, in the family. Only then we can do this. And then it has to be as per the PCPNDT and ART guidelines, the rules and laws. That needs to be stated. Yes.
Okay. So अगर कोई कपल है जो प्रेग्नेंट है और उनकी फैमिली में हिस्ट्री है कैंसर का, राइट, एंड दे कम एंड दे वांट टू टेस्ट, और उसमें क्या थ्रेशोल्ड होता है? फॉर एग्जांपल यू सेड 50% चांस है, तो इस 50 द थ्रेशोल्ड अगर उससे ऊपर जा रहा है तो यू विल सजेस्ट देम गो फॉर IVF, या कुछ नंबर डिफाइंड होता है सर?
Yeah, so there are different patterns of inheritance. So
Okay.
We have not talked about it. Let me orient you to that facet of genomics. So कई बार ऐसे होता है कि you're talking of one genetic disorder and you see every generation someone is having it. Right. So say certain traits, not disease, but a variation of normalcy, height. Dada was very tall, father is very tall, son is also very tall, but बीच में होता है कि पोता is not tall, is average height, but उसका जब बेटा होता है he's tall. So these are traits which are governed by your genes. But again, not necessary कि वो gene जो trait govern कर रहा है, it should manifest in every generation. It can skip. तो this is like autosomal dominant. अगर वो variation है तो वो manifestation होएगा ही, like say 90-95% of the times. So these are autosomal dominant.
Right. समझ गया.
Because we carry 2 copies of every chromosome, every gene. तो उसमें एक variation है, उसके वजह से जो features आने हैं वो आएंगे. अगर एक में variation एक normal है तो ठीक है. सेकेंड होता है ऑटोसोमल रिसेसिव.
ओके.
उसमें कैसे होता है कि दोनों कॉपीज जब डैमेज होती है या वेरिएशन होता है, only then the manifestation happens. This type of genetic abnormalities are prevalent.
Okay.
Because अगर किसी में एक भी वेरिएशन है उसमें मैनिफेस्टेशन नहीं होगा, उनका टेस्टिंग हम करते नहीं है. एंड अगेन थिंग्स लाइक कॉन्सैंग्विनिटी, मैरिजेस इन रिलेशन, फर्स्ट कजन, सेकंड कजन, मैरिजेस इन क्लोज्ड कम्युनिटी, इसमें फिर देयर आर सर्टेन डिसऑर्डर्स जिसका प्रेवलेंस ज्यादा है बिकॉज ऑफ this मतलब endogamy sort of.
Endogamy. ये इंडिया में बहुत है, right? Because
Yes.
obviously, I mean, I'm not commenting on any caste system, but we have this social structure in India
So
जो हजारों सालों
that's
से
quite
चल के आ
common.
रहा है.
Yeah, it's even in the West, even here. तो उसमें there are certain like apart from the consanguinity part also, if you see Sindhis, Punjabis,
Yes.
Rohanas, sickle cell thalassemia is quite common in that cohort.
Okay.
If you look at the geographical region, if you start from say Nandurbar, Jalgaon, Amravati, Chandrapur, Nagpur, that belt, that's a tribal belt where again sickle cell thalassemia is quite common.
Okay.
So this is known in general population in India. So there are conditions like say sickle, thal, spinal muscular atrophy, certain inborn error of metabolism, which are common.
समझ गया.
These are most of them are autosomal recessive. उसमें the important aspect is both partners may be having that variation, but एक normal जो gene या allele है वो काम कर रहा है, they will not manifest. Clinical features होंगे नहीं. It is only when the child is born because of inheriting both the faulty alleles or genes from both the parents, then the diagnosis comes out.
अगर मैं इसको simplify करूँ and you can correct me, right? कि जो social structure है इंडिया का, XYZ समझो एक कास्ट है और मोस्टली उसी कास्ट में शादी हो रही है 200 सालों से 300 सालों से, तो एक चांस बहुत बड़ा है कि जो अभी कपल है उनके शायद एंसेस्टर सेम हो, जिसके वजह से जो डीएनए है जीन से हो सेम आए और जिसके वजह से abnormality पैदा हो सकती है.
Okay, so just to draw parallel with this,
yes,
when in genetics clinic we take a family history, it's very common. 3 generation के ऊपर का नहीं पता होता है.
नहीं पता होता है.
That's quite common, but that's the limitation because there is a nuclearization that is happening. Small families. We are not interacting much with our first degree, second degree relatives.
True.
That information is not there. So that is the reason carrier status may be there. Second degree, third degree relatives, there may be people who are affected, but we don't know.
No.
So for such conditions, then it's better to have a screening done. So next step. जैसे it's scientific. शादी के पहले कुंडली मैच करते हैं.
Right.
I'll say शादी के पहले तुम्हारा जीनोम मैच करके देखो what is the risk.
Yes, exactly. आज के तारीख में तो it's required.
Yeah.
Yes, sir. Please continue.
So for this shadi.com, matrimonials.com, we can have a tie-up.
Makes sense.
Because if the risk is there, you'll know the risk beforehand.
Right.
We can avoid the risk.
Yeah.
Where appropriate, we can offer a conceptual genetic consult. What is the risk? How we can avoid prenatal diagnosis कब करना है? And if the couple like prenatal diagnosis is done when pregnancy is already there, risk is already there. उसमें God forbid, agar if we find that the fetus is affected, then it's like a irreversible decision. Only option that remains is a medical termination up to
abortion.
Yeah, up to a certain extent of gestation that is permitted under the PCPMDT.
Okay.
Right. Can we avoid it if the disease is severe? ठीक है. So like I had a couple who are planning pregnancy. On both sides of the family, there is a history of recurrent miscarriages, bad obstetric history. There is history of mental retardation, intellectual disability on the lady's side. So in such cases, if we do a test, we can actually know what could be the risk starting for the first pregnancy, even before planning. And if the condition is significant, neurodevelopmental, where you know what the consequences are going to be, in those cases, IVF with pre-implantation genetic diagnosis, that makes sense.
Yeah.
We can actually avoid. So that risk, if it is 25%, by doing IVF with PGD, we can bring down that risk to less than 1%.
So sir, हम lifestyle की बात कर रहे थे, right? And with lifestyle you mentioned if you don't smoke, don't drink, regularly exercise हम करते, तो जो आपके कैंसर की probability है अगर inherit हुई है तो कम हो जाती है, right? इस पे एक थोड़ा नॉन सीरियस क्वेश्चन है मुझे, क्योंकि यू नो वाइल ग्रोइंग अप आई हैव माई फ्रेंड्स यू नो जो स्मोक करते हैं, ड्रिंक करते हैं, ठीक है। अब उसमें वो ये बोलते हैं कि यार मेरा जो दादा था, मेरा ग्रैंडफादर था, वो 90 साल जिया और उसने इतना स्मोक किया, ड्रिंक किया, उसको कुछ नहीं है, उसके दांत भी नहीं गिरे। तो इज दिस समथिंग दैट जीन्स कंट्रोल?
Yeah, so you must have known about this person, Mr. Winston Churchill.
ऑफ कोर्स, या द डार्केस्ट स्टार, उसकी मूवी भी है, इट्स गुड।
So he used to smoke, he used to drink, we all know, but he lived till 90 years without any this thing. So yes, you're stronger the genetic makeup, more your body resists against the adversities that it is exposed to.
So-
But everyone doesn't have it.
Yeah,
Once you know there is a predisposition, why to take risk?
true.
And having said that, even if you have a good genome with you, not necessarily it will protect you all the time.
Not to buy to abuse it.
Yeah. So like for they say for liver it has a very huge reproductive potential. It keeps regenerating. Sorry, not reproductive, regenerative potential. Whatever insults the liver goes through, it regenerates. But then there's a limit. Beyond that, things start failing. So
True.
that's what happens with chronic alcoholism. It keeps hitting the liver. Liver keeps
Eventually.
bearing it, but eventually there comes a time when that threshold is breached. The damage is irreversible. Then you cannot, get back
Yeah.
on the track.
सो आई थिंक अगर कोई स्मोक करता है, ड्रिंक करता है, तो उनको टेस्ट करा लेना चाहिए फॉर जीनोम, राइट? जस्ट टू अंडरस्टैंड कितने रिस्क पे है वो।
Yeah. So one way of putting it, but again, why to expose yourself to the harm that you know it is?
ऑफ कोर्स, आई मीन अगर आप नहीं करते हो तो मत ही करो, बट
We can do it for a better cause, maybe say pre-marriage, preconception.
राइट,
If there's a family history, first get a consult done to
Right.
know are you eligible or is there an indication or reason, valid reason to get the test.
ट्रू,
Then comes the second part, which test, which platform, what is the coverage, is it appropriate? Because there's a fancy nowadays, lot many clinicians I find, so nowadays I find patients, they straight away come with the report, sir ये problem था, डॉक्टर के पास गया, ये टेस्ट कर ले, this is the report. And quite a few cases I find it very fascinating because either the test was not needed,
ओके,
it was some other test that should have been done, or the platform on which the test was and had its limitation, this thing was not covered.
तो ये जो गलत टेस्ट आपने बोला, आई थिंक कि नॉट नीडेड फिर भी किया।
So this is I'll put it with a caveat. This is because of the limitation of
Okay.
knowledge for the clinicians.
Get it.
So like if I'm a radiologist, I'm doing an MRI.
ट्रू,
Okay, I know if I'm having a patient with stroke, what to look, where to look, how to interpret. I'm trained that way.
या,
If I'm an orthopedician, I fix bones,
राइट,
whether it is a sports injury or whether
Right.
it is a road traffic accident,
Right.
or this is a simple dislocation that has happened.
राइट,
I know because I'm trained to do. Similarly, as a medical geneticist, I have been trained in medicine. I have done MD medicine 3 years. So similarly, my colleagues who are pediatricians, they have done 3 years of pediatrics, post MBBS, or say obs gynae. They have done obs gynae for 3 years. And after that, they've come and done a DM course that is again 3 years.
समझ
You have improvised ourselves in applying that medical knowledge in the medical field. So
समझ
reproductive genomics. If I'm talking of infertility, okay, there are other causes, autoimmune, hematological, infections, and so on. Genetic is one of them.
Right.
So
Something
when
like
to investigate, which test to do. If I'm talking about recurrent miscarriages, okay, singleton couple, no other significant history, causes differ. But again, if there's a history, couple is having recurrent miscarriages, husband, his brother, that couple, they are again having recurrent miscarriages. Husband's parents, even they had recurrent miscarriages and then they had 2 kids. So if it is going on in the family, I know what set of abnormalities to look for, what test to go in for first. Get trained that way.
समझ गया.
If I'm looking for inborn error of metabolism, right? And again, there are, I'm also, as a medical person, I'm looking at the differentials of those medical disorders as well. So there could be two medical disorders, clinically look similar, but at the molecular level, there are abnormalities which are way apart, which one test will pick up, other will not. But when I'm doing ordering a medical genetic test, I know, okay, so that's what the variation happens when a clinician orders, like suspicion is there, orders a test, but that test is not picking up this gene, this abnormality, this variation. That may be a technical limitation, limitation of the platform, of the database, or whatever. Test comes negative and the clinician ends up frustrated. Yeah, my clinical diagnosis is spot on, but the test is giving negative result. Why that? So this is the limitation. So and then there is one part that is counseling. Apart from the medical disorders, the diagnosis, we just not only order a medical genetic test, but we also advise other investigations to zero in on the clinical diagnosis, to confirm the clinical diagnosis. So this could be other hematological investigations. It could be spectrophotometry investigations, could be imaging, CT, MRI, ultrasound, could be hormone levels, right? Anything else, ultrasounds maybe. So all these enzyme levels, so to zero in. And then once we have a clinical diagnosis, then we look at the molecular part. And counseling, pre-test and post-test counseling as well. So I'm doing a consultation. I'm doing a medical diagnosis. I'm doing a pre-test medical genetic consultation and counseling. The test happens, the report comes, then post-test and also the management part. So management part, in certain domains, it's a teamwork. So if there is a neonate diagnosed with a genetic disorder, inborn error of metabolism, the neonatologist is involved, NICU people are involved. Once the baby grows, the pediatrician is involved. Then there are nutritionists, dietitians, they are involved. And once in the developmental phase, developmental pediatricians and so on. So it's a teamwork.
समझिए. मेरे को आपको एक चीज़ पूछनी थी, आपके this career, glorious career you have, कि आपने कोई ऐसा केस देखा है जहाँ पे किसी को स्टेज 4 कैंसर हो एंड यू थॉट कि शायद चांसेस आर लेस, बट कुछ मिरेकल हो के टेबल्स टर्न हो गए एंड
so quite a few cases that I can recollect.
So इससे क्या होगा जो अभी जिनको अभी स्टेज 4 डिटेक्ट हुआ है, they will also get some hope, right?
Yes. I think 2024 November, December, there was a very nice case series that came out for colorectal cancer, stage 4 colorectal cancers, some new drug. I am not able to recollect the name of the molecule, but I think 12-13 cases there were. The number of cases was less, but the results, all those patients cured from stage 4. So that's a published case series.
ये कहाँ पे, where was this
I need to recollect. I can give you the reference.
Yeah,
that's
we'll
one.
Put it, yeah.
But to quote, there is one very important case study for all of us to understand how science can guide us when we are in despair. So you please note down this name, Dr. Lucas Wortman. Okay, so this guy, himself a doctor, working in Stanford University on leukemias. In due course, he himself diagnosed with leukemia.
Okay.
First line of treatment failed, second line of treatment failed, like time running out, nothing is working. And his team was working on molecular genetics of cancer.
Okay.
So the team took a decision, and then they did analysis for his hematological malignancy. They did a transcriptome study.
Okay.
What they found, there was one particular gene which was upregulated, causing a problem, triggering the hematological malignancy. Luckily for that particular gene, for that particular variation, there was a drug which was already available in the market, but licensed for renal cancer.
Okay.
That drug was repurposed after
this
tumor board and all what that happened in Stanford. And that guy is, still around. So there are complications and other things, like but still something, first round of treatment, second line of treatment has failed, and then you're going for something like this. So that's how it is. Like, more we unravel at the molecular level and try to correlate it to the clinical thing. So just to put in, we know a lot now compared to what we knew earlier, maybe a few decades back.
Yes.
Having said that, there's still much more we don't know.
True.
I'll say we are at the initial phases of learning, and much research is already going on. Maybe in next 2-3 years, we understand much more and deeper, that makes a wiser and improvisation on treatments happen.
Makes sense. Yeah. So I don't know how true is this. You can correct me, right? There are obviously human genes, and there is also microbial genes, जो gut microbiome बोलते हैं. So is this true कि ये दो तरह के genes आपके body में होते हैं? And the microbe genes also affects your mind, brain.
So let me simplify this thing for you.
Okay.
So how many cells approximately are there in the human body?
Billions.
30 trillion.
Trillions.
So उसमें एक सेल का क्रोमोसोम निकाल के स्ट्रेच करते हैं पूरा. It's approximately 2 meters.
Okay.
30 trillion cells.
में 2 meters.
2 meters DNA. So if you calculate the distance from, say, Earth to Sun, you can come back and 2 and 4th. 100 times. From a single human body, the amount of DNA that you can extract. So look at the enormity of it. And everything is compacted at a microscopic level where we cannot see it with naked eyes.
Right,
we have to use microscopes and all. Right. So when you're talking of gut microbiome, so there are more microorganisms in the gut than the cells in the human body.
Okay.
I just wanted to give you that reference. Okay. So microbiome, this bacteria and so on.
More than 30 trillions.
Yeah. There are more microbiome that we carry than our own cells.
Fascinating.
So they are on the skin.
Yeah.
They are in the hairs, hair roots, hair follicle around that, in the gut.
Right.
Even in the oral cavity. Right. Each microbiome, each microorganism has their own genome. There is a variation. Like we have DNA as a primary genomic material. It's a double helical structure. Some organisms have a single stranded DNA or a double stranded DNA.
Right.
Size varies.
Yes.
Some organisms have RNAs as their primary genomic material. So this varies.
Right.
So when we are talking of a gut microbiome, so basically these organisms, they have their own functioning because whatever we eat or we put in our guts, everything doesn't get digested per se or absorbed per se.
Right.
We secrete certain content in the lumen, what we call as, say, gastric acid, bile and so on, which helps digest and absorb. And apart from that, there is certain amount of chemicals or, say, factors
juices,
that come in from these microorganisms which aid. So that's why we have this concept of good microbiome
and bad
microbiome.
Yes.
And having said that, there are studies which show, depending upon what gut microbiome you carry, the propensity, and there has been some association with intellect, autism spectrum disorders.
Okay.
So some evidence is there. I think I need to update myself on this. I'll be upfront about it.
No, that's fine.
So that's a different segment of genomics, what we call as metagenomics.
Metagenomics, okay.
So I'm into clinical genomics.
Okay.
So you have molecular genomics, molecular pathology, metagenomics. Then what we discussed earlier, depending upon the lineage, ancestry. Okay. So conservation across species, that's anthropogenetics.
Yes.
Then you have forensic genetics, where you investigate the crimes and all that. So genetics has different sub-specialities in it.
So it's a growing field.
Yeah. So even if I'm talking of clinical genetics now, even in clinical genetics, there are subspecialties now.
Okay.
Like suppose in medicine, we have subspecialty, nephro, neuro, cardio, immuno, onco, so on.
Yes.
Even in genetics
Yes.
now, this subspecialization is happening. You have cancer genetics, you have metabolic genetics or inborn error of metabolism and so on, neurogenetics, nephrogenetics, immunogenetics,
Okay.
ophthalm genetics, then dermat related, genodermatosis, what you call inherited conditions, reproductive genomics, then
Okay.
lab genetics.
So
So
it's
it's a growing
it's a
and
wi-
upcoming field. Yeah.
wonderful. So इज दिस ट्रू जब बोलते कि जो आपका डीएनए होता है आपने आई थिंक बोला भी पहले कि 50% इज मॉम 50% इज डैड राइट बट देयर आर फ्यू ट्रेट्स यू नो दैट आई वांटेड टू नो फ्रॉम यू इज इफ इट इज इनहेरिटेड फ्रॉम डैड और मॉम साइड जैसे स्लीप पैटर्न
So this inheritance is random.
अच्छा.
Whatever genome you get,
हाँ
you
इट्स
could get it from either of the parent.
ऐसे जरूरी नहीं है कि
ऐसे
अगर
कि इससे हाँ. But there are certain genes where
हाँ
imprinting happens.
Okay.
So that means the gene which is coming from mother, only that will function. From father, it will not function, or vice versa. So what we call is that imprinting disorders. So a gene from one particular pattern gets imprinted, the other gene functions. And if vice versa or deletion or some abnormality happens in the normal, then a genetic disorder will happen. So these are epigenetic disorders.
Okay.
Something that's above the genome.
तो जैसे you know few things like आपके eye color हो गए weight intelligence it's not necessary
It's not fixed that this will come from mother or
Okay.
it can come from anyone.
Get it. And then you know when I was researching थोड़े और puzzles I came across few things जैसे this thing called MC1R mutation is जिसमें अगर किसी के naturally बाल रेड है तो इट इज बिकॉज ऑफ दिस जीन म्यूटेशन ऐसा होता है फिर बोलते हैं अगर किसी ग्रीन आईज है मे बी दैट इज बिकॉज ऑफ सम
Yeah, so you have variations in those genes,
Right.
those particular genes which govern
right
the phenotype or clinical appearance
Right.
of that particular individual. So there are certain genes, if you have a issue there, you'll have hair on your ears.
okay
So that's Y chromosome related. The only disorder that is or a condition that is attributed to Y chromosome. Otherwise, everything is autosome and X chromosome. So there, color of your eyes, propensity to weight, appearance, physique, hair. So these variations are governed at a molecular level by typical genes.
So इसमें एक और चीज़ है इट्स यू नो फॉर यूजर्स यू नो जो बॉडी बिल्डिंग करते हैं तो देयर इज वन म्यूटेशन कॉल्ड एज मायोस्टेटिन MSTN कोई तो पेपर में आई थिंक इसका रिसर्च पेपर आया है उसमें ये होता है कि आपके जो बॉडी में हाईली अनयूजुअल मसल्स डेवलप होते हैं तो ऐसा लगता है कि आपने स्टेरॉइड्स लिए अगर कोई नॉर्मल ह्यूमन बीइंग आपको देखेगा तो लगेगा ही इज ऑन स्टेरॉइड्स पर वो होता नहीं दैट इज बिकॉज ऑफ दिस म्यूटेशन तो this
I need frankly see.
no, I'm just bringing this up.
See, there are more than 21,000 genes.
Yes.
मैंने मतलब अपने in my journey of past 10-12 years or more.
Right.
जब मैंने DMB किया.
Right.
I've hardly कितना genes देखा होगा या कितने conditions देखे होंगे. Its entire lifespan will be less to go through all that. So it is like whatever we see, we analyze, correlate, and document, and we go on.
Right.
So myostatin and this, there are certain genes which govern your appearance. Any aberration in those may have a particular impact on your clinical pattern.
Okay.
That may be there. So for this particular case, we need to see.
समझ गया.
It's like someone is having a headache, you give a paracetamol, one person gets instant relief, another doesn't get it, or some gets adverse reaction, depending upon what's your capacity to metabolize.
Right.
So that is governed at molecular level by your genes and your enzyme that are supposed to metabolize.
जैसे you know, I know few people अगर वो बाहर का खाते
pharmacogenetics,
immediately उनका गला पकड़ लेता है. So is that also something related to?
Some people have immunological conditions which are genetically predisposed, like primary immune deficiency disorders. But that's a
right
like very severe part of this
समझिए
immunity related.
ठीक है, आई थिंक वी आर ऑलमोस्ट एट द एंड ऑफ द पॉडकास्ट. मेरा एक क्वेश्चन है, इज न्यूट्रिशन ग्रेटर देन जेनेटिक्स? अगर आपको जेनेटिक्स इशू है, आपको कैंसर होने का इशू है, बट आपका न्यूट्रिशन अच्छा है, तो व्हाट आर द चांसेस यू कैन डू अवे विथ?
So, see, when you exercise,
Yeah.
when you follow a healthy lifestyle, when you take a good diet, good
Right.
nutrition,
Right.
this governs the expression pattern of your genes.
Right.
So, what the upcoming field is nutrigenomics.
Nutrigenomics.
Yeah. So,
Yeah.
if you're very careful about this,
Okay.
your gut, your digestion, everything falls in place. So any adverse things that could arise in due course, they
Right.
can be, the risk can be cut down.
Risk can be cut down. So nutrition is very important.
Yeah, and this is being scientifically proven. So like we have a diet, suppose an individual is taking diet which is deficiency in one particular say vitamin.
Right.
In due course, because of that vitamin deficiency, whatever manifestations are happening, that will be evident. Why? Because that vitamin is supposed to work as a cofactor or some receptor it is helping. Some molecular pathway in the cell it is supposed to augment. That is not happening, and because of that, the molecular pathway, however it is supposed to function, that functioning is not happening, and then the deficit. Then it manifests in a particular pattern. Like for example, you have vitamin C deficiency, you will manifest with scurvy. Right. Then your healing wounds and all those things. So that vitamin C is important for your development, growth of your fibers, the collagen and all that. So that one deficiency it will manifest somehow.
All right, just last two questions. These are little fun questions. I was reading about this thing called gene editing, जहाँ पे they have mentioned maybe in future, it's a sci-fi concept, I don't know, कि आप डिज़ाइनर बच्चा पैदा कर सकते हो विद जीन एडिटिंग. आपको जिस तरह से आँख चाहिए, जैसे आपको फीचर्स चाहिए, आँखों का कलर चाहिए. Is that a possibility in the future? What do you think? Or just good to discuss a theory?
Possibility. So as we are talking, there are aquariums.
Right.
You go to Japan, you go to Europe, you go to US. So whatever type of fish you want, the fish color, the fish size,
Achha.
you give them the specifications, and in few days they'll give you a fish for your aquarium. So it
happens in Japan.
It's happening. So
it's a possibility for human.
So हम बेर खाते हैं, पियर.
हाँ.
पहले बहुत छोटे छोटे आते थे,
Right.
now वो एप्पल
के साइज के हो गए.
How?
Mutation, yeah.
So this is like the positive effects that we have drawn.
Yeah.
Right. This is all the impact of genomics in agriculture.
समझ गया.
Right. So what you're asking may be practically possible.
Okay.
But then there are limitations, rules, regulations, ethics, morality, other aspects. Yeah. So gene editing for disorders. So there are therapies now which are licensed.
Okay.
Gene therapies where gene editing is done.
All right. In India?
It is licensed all over the world. So,
wow.
So these are gene therapies where either you're correcting the genetic abnormality that is there, or you're replacing that segment with a normal segment.
Okay.
Right. So this is for certain conditions, like for sickle, for thalassemia, for certain enzyme deficiency disorders, particularly the eye conditions, retinitis pigmentosa related. So I think more than 24 gene therapies are right now licensed as we're talking, and the number is increasing at a very rapid pace. So correcting these disorders is possible. Right now it's quite a few, as we can count on fingers, but going ahead, it's going to be huge.
Yeah, I think gene editing is good for, ensuring
but
आपके
it
health
comes
is for baby designer babies.
designer
may be
baby.
far stretched at this stage.
Designer babies, no comments. But for particular disorders, yes.
Okay.
For treating those individuals, yes.
Right. Now, last question, and this question might not make any sense to you, but let me know what you think. So I read this book by Blake Crouch. He's a sci-fi writer. Pine Trilogy. अब वो बुक का बेस क्या है कि ह्यूमंस का डीएनए जीन्स इवॉल्व हो रहा है. पहले भी हो रहा था हजारों साल पहले, और वो होते रहेगा. तो उसमें ये होता है कि आज से 5,000 साल बाद, 10,000 साल बाद मे बी ह्यूमंस ना रहे. उस बुक में ह्यूमंस को एबी बोला है. तो एक नया तरह का एनिमल पैदा हो जाता है ओवर द कोर्स ऑफ टाइम, एवोल्यूशन, राइट. सो बिकॉज ऑब्वियसली इफ यू लुक बैक एट द हिस्ट्री, वी वर लाइक अ सेल, राइट. फिर हम मैमल्स बने, एंड होमो सेपियंस, एंड द रेस्ट मॉडर्न ह्यूमंस, राइट. सो अगेन साइफाई थियरी में भी, डू यू थिंक आज से बहुत सालों बाद कुछ ऐसा होगा, मे बी ह्यूमंस विल नॉट बी ह्यूमंस because genes, DNA is evolving?
So two different individuals, two different homo sapiens,
right,
they share 99.9% of the DNA.
Okay.
Between chimpanzee, monkeys and
Yes.
us, 99%.
99%.
With a banana, I think 70-80%.
Banana? Fruit?
Yeah.
Okay.
We share our genome with the banana also.
Okay.
With different vegetables also, 30, 40, 70, 80%, we are sharing the genome, same genome.
That's
right?
fascinating to know.
So our genome is 3.3 GB. We are such a complex organism,
Yeah.
animal,
Yeah.
social animal, whatever.
Right.
What is the size of genome of an onion?
I don't know.
You have Google? Go ahead. Let's see. It's interesting. I want you to search, and I want to see the look on your face. So I'm talking of human genome. It is 3.3 GB. I am asking you to look for genome of an onion, genome size of an onion.
Okay, let me check.
What does it say? In fact, with AI, they'll give you much more.
14.9 to 16.4 billion base pairs, GB.
So that's
right?
like, so
For an
3.3. So this is 14, like almost 5 times.
Yeah.
So onion genome is much more than the human genome.
And it's so smaller in size compared
Yeah.
to humans. So it's
So-
crazy.
So that's what when I said earlier, we know a lot.
Yeah.
We started to know, but still we don't
Yeah.
know anything. So
No.
what will happen in future? It's difficult
Yeah.
to say. What has happened till now, that's very fascinating. But we are at a very fascinating juncture in the evolving phase of
Exactly.
molecular genetics and clinical genetics. Yes.
All right, I think that was it. Dr. Anup, thank you for your time. And
should thank you.
We learned a lot about DNA, genes, and also before we wrap this up, आप mention कर रहे थे कि you are going to attend a conference that would be first in Maharashtra, right? If you were like
Not a conference, a camp.
A camp,
So
yeah.
So tomorrow I'm just shooting off to Alibag with my team of doctors from E01. So
Okay.
that's a new hospital that we started on Apte Road. I didn't get it. I'm saying the first because I didn't get any reference anywhere on. I tried to search if anyone has conducted, but this is the first medical genetic clinical camp open to all specialties that we are conducting on Sunday,
Right.
the 1st of Feb in Alibag. So the details are there on LinkedIn and Facebook.
Yeah.
So
you can share, and then we'll
yeah.
update
So the consultation in the camp will be by purely on registration basis.
that. Okay, समझ गया. So I think that was it. Thank you, Dr. Anup, for your time today. I think आज हमने बहुत कुछ सीखा DNA, genes के बारे में, especially how your genes affects your health, oncology, cancer, right? And why a pregnant woman should, or couple in that sense, do the genes test to ensure there's no risk. और भी बहुत बात करना है, but we are running out of time. Maybe we can have a part 2 later.
I'll look forward to that.
Yeah. So thank you so much. I really appreciate.
Yeah. Thank you so much. It was a pleasure interacting with you, Ashish.
All right. Thank you for being on Between Lines. And Folks, please do subscribe to my channel, Between Lines by Ashish Sharma, and do give a thumbs up. Thank you.